Good afternoon. I'm Dr. Lenny Iboleon-Dy, the Chair on the Council of Cardiovascular Health. And it's my privilege to open the session on women's cardiovascular health. We have a powerhouse panel of discussions and lecturers. And we'd like to start by calling on our first, Dr. Maria Belen O. Carisma, Examiner of the Specialty Board of Adult Cardiology and the past President of the Philippine Heart Association, as well as the past President of the Philippine Heart Rhythm Society, to talk about the cardiovascular consequence of obesity. Dr. Belen Carisma.
Thank you very much, Dr. Maria Adelaida Iboleon-Dy. Lenny. That's my disclosure. So, well, it is, I think, not an uncommon knowledge for all of us that obesity is now a global epidemic. It is said that about, since 1980, the obesity prevalence has doubled. And we can see it for ourselves, no? If we look around. And about 30% of the population are found to be obese, and we know what causes this. Insofar as the ASEAN region is concerned, these are data, I think in the early 2000s, if not in the late 90s. In Malaysia, the prevalence of obesity is around 4% for men, 7% for women. In Myanmar, it's 4.3% for men, 8.4% for women. In Singapore, I always thought the Singaporeans are leaner and slimmer, but the prevalence of obesity is around 5.3% for men and 6.4% for women. In Indonesia, the obesity prevalence is at 1.3% for men and 4.5% for women. In our motherland, the prevalence of obesity is 5.2% for men and 6.6% for women. Thank you. All right, so if we go to definitions, if we go by BMI, which is now what we use, no, well, we have been using it, underweight would be less than 18.5. Normal would be anywhere from 18.5 to 24.9. So you start getting your BMI by computing your weight in kilos over the height in meters squared. Overweight would be from 25 to 29.9. And relating this to the risk relative to the normal weight and waist circumference as shown in the slide, there is now an increase in the risk for development of diabetes, hypertension, and cardiovascular disease. From overweight, as you go up the scale of obesity, class 1, 30 to 34.9 BMI, class 2, 35 to 39.9, and extreme obesity class 3 is equal to or greater than 40. It's a yucky picture, but just shows the negative effects of obesity on our health and our lives, from lower life expectancy to joint problems, heart attacks, breathing problems, high blood pressure, type 2 diabetes, high cholesterol, arthritis, not to mention the social, psychological, negative effects of low self-esteem, depression, limited mobility, and social discrimination. So I would just like to run through the noted or well-known cardiovascular consequences of obesity. We have cardiomyopathy, otherwise known as adipositas cordis. Of course, we have venous insufficiency and concomitant venous thrombosis and pulmonary embolism, hypertension, sleep apnea, stroke, coronary artery disease, congestive heart failure, and of course, arrhythmias. Now, there are two hypotheses postulated for the causation of cardiomyopathy, that the fatty heart is a metaplastic phenomenon where cords of cells accumulate in between muscle fibers to cause either myocyte degeneration or not, but simply there is fat in between the muscle fibers causing cardiac dysfunction. The other hypothesis is that there may be lipotoxicity of the myocardium induced by free fatty acids causing apoptosis of lipid-laden cells, such as cardiomyocytes. Now, this is an example of a case report from an obese individual where the histological view shows the right ventricular free wall showing transmural fatty infiltration, occupying approximately 50% of the wall thickness. In this case, the myocardium is preserved, but there is dissociation, actually, because of the fat cells in between. So there's also venous insufficiency. We know that because of a common finding of pedal edema among obese patients, which is due to the elevated left ventricular filling pressure despite cardiac output. There's also, because of the increased mobility, and therefore the pumping action on leg muscle, resulting in blood in the legs. Inevitably, stasis may result in pre-ulceration, cellulitis, and understandably increased risk of pulmonary embolism. Of course, this obese, it's a forensic report. Carl died. It was mass embolism. The context of low deep vein thrombosis in the bottom panel showed the thrombi that were extracted deep in the legs. Hypertension said that low weight is associated with millimeter mercury systolic and 2.3 mercury systolic blood. Individual who is with a 12 increased risk for coronary heart disease and 20% risk for stroke. Prevalence of hypertension when obesity is nominal distribution. So what links obesity to hypertension? Of course, there are effects in dynamics. There is increased volume and cardiac output. There are linking obesity and increased resistance, cochlear dysfunction, causing resistance, causing also increase of the sympathetic system, and increased release of substances from eyes. Factor are meters of interleukin 6 and cirrhosis factor. Sleep. No, friends who are just have apnea, but so if they're obese. Obesity is supposed to be the most modified risk factor, sleep disordered breathing. Understandably, obesones have increased the ventilator load, the respiratory inefficiency, they have dysfunctional respiratory resume. But there's also closed peripheral lung, resulting in ventilation mismatch. And obesity is purported classical of alveoventilation, as the cartoon may show. Stroke studies have shown an obesity and weight ratio and stroke. Each unit of BMI is associated with multiple decrease, 4% the risk of ischemic and 4%. However, for ischemic associated BMI. Now, why is stroke predicted by thrombotic pro-inflammatory state? See, adipose accumulate. Coronary artery disease, coronary patients in women lag behind by 20 years compared to those of men. That's something to about. Preferential deposition center menopause may in part explain why the risk for coronary events increases than men. And several perspectives, such as the Framingham Manitoba study, have documented obesity to be independent predictor clinical coronary heart. The trace real evaluation showed that more than 3% on patients abdominally obese compared to those who were nominally obese. Congestive heart failure. The rated BMI exposes congestive heart by hypertension and coronary disease. Risk of congestive heart failure 16% for men and 7% for women. For each increment of 1 U of BMI, with urgent threshold. Once with congestive heart failure, the presence of obesity may adversely affect the outcome. Arrhythmias, something close to our stable obese have arrhythmias in absence of cardiac function. The risk increasing is seen in gender. And in the frame study, the risk of death around 40 higher rate of cardiac arrhythmia match this population. For QT, we know QT facilitates enables of life-threatening arrhythmias. Prolonged QT was seen percent with impaired glucose tolerance, such that there is positive and prolonged QT. The clinical significance of the associated prolonged, however, remains speculative. One is that the high glucose may promote increased tone, instability, oxide of it. Some attribute QT to the vagal imbalance. A 10% increase in body is seen to be treated and in parasympathetic tone accompanied by a rise in mean heart. The good news is that weight loss of obese patients is associated with significant nervous system cardiac modulation. So these are the list. This is the list of the ECG changes that occur in intervals. Increased sympathetic system activity, increased PR, QRS interval, or in the QRS with mention of QT interval, QT dispersion, signal average rate potential, non-specific ST abnormal, ST, you may have LAD or left activation, and so on. Again, benefits of weight reduction on the cardiac system may be in the blood volume, decrease in the volume, pulmonary capillary pressure, in the LV, leading to improvement of LV diastolic dysfunction, improvement of LV dysfunction down the line. So, we have other guests in this session, and precisely we need them to address the problem of obesity. Thank you very much.
Thank you, Donna. We need second speaker. I don't know why the chair. It's been here all. Tinagalog ko kasi ng girl niya. Talk on women's obesity, cardiovascular consequences. After the case presentation discussion, we'll have time to consequences. Room wise obesity. We have an Endo as our speaker. Clinical at the University of the Philippines General Hospital and active too at the Cabrini Medical Center Institute. Again, to talk on the why women's obesity, come Maria Cecille S. Añonuevo-Cruz.
Afternoon. In minutes, we went through the reason women weight. And first of all, I would also like to thank the Philippine Heart Association for this opportunity to be part of this panel discussion on a very important topic that is close to our bellies and our hearts as well. These are my disclosures and my personal permission to disclose as well that we all have an impassioned struggle against weight. And likewise, being a mom myself, and likewise being an aging woman, as all of us are, we also have our own personal struggles, as you would know, particularly on visceral adiposity and polycystic ovary syndrome. So at the end of this presentation, we will be able to appreciate the peculiar reasons why we gain weight throughout our lifespan. And for women, these different factors are interestingly intertwined with genetics, environment, and likewise aging. And we do know that obesity is a public health concern because of the additional risk it poses for the development not only of cardiovascular disease, but even other comorbidities, including diabetes. And recently, the American Association of Clinical Endocrinologists and the American College of Endocrinology proposed a new diagnostic term for obesity, which is adiposity-based chronic disease, or ABCD. This is to explicitly identify obesity as a chronic disease and alludes to precise pathophysiologic bases, and likewise avoids the stigmata and confusion related to the differential use and multiple meanings of the term obesity. And what we would also want to be able to appreciate is that over the years, we have developed, or we have come to know, traditional factors that would tell us, or would indicate, that would indicate known factors for gaining weight over time. And likewise, at the end of this presentation, we would also be able to appreciate some new and somewhat interesting novel factors that would make women gain weight over time. And in the recent Food and Nutrition Research Institute survey, particularly looking at the National and Nutrition Survey in 2013, they were able to glean that among Filipino adults, 20 years or older, 3 out of 10 were obese, based on a BMI cutoff of 25 kilograms per square meter or more. But we do appreciate that in the Asia-Pacific International Obesity Task Force, obesity and overweight are also defined even more conservatively, so that this number would probably be different had we used a more stringent means of identifying obese individuals. And quite interestingly, it is not only BMI that would make an individual obese, but it would be more for their waist circumference, knowing that the waist circumference is likewise a very good indicator of visceral adiposity. And quite interestingly as well, if the average waist circumference for males was around 80.4, for women, as you would see the curve or the bars crawling up, we would appreciate that over time, compared to men, we Filipino women, as much as women all over the world, would have increasing waist circumferences, and they were able to appreciate that the highest waist circumferences were appreciated in women ages 50 to 59 in this particular survey in 2013. Based on the deciles, we were also able to appreciate that Filipino women tended to be more abdominally obese with age. And since its inception in 1993, the waist circumferences of Filipinos in the different surveys every 5 years have continually increased. And why is this so? We might appreciate as well that genetics do play an important contribution to how an individual gains weight over time. Over the years, based on twin studies, there has also been a tremendous expansion in the knowledge base regarding obesity and how genetics also play a role in determining who eventually becomes obese or overweight. And studies involving families, twins, and even adopted individuals have indicated consistently that adiposity is truly heritable, so that it actually accounts for about 50 to 90% of the variance in BMI in twin sets, particularly monozygous twins. Data from adoption studies, on the other hand, are consistent with genetic factors accounting for 20 to 60% of the variation in BMI. And even fluctuation in BMI seems to be also dictated or influenced by genetic factors. As we can see, one of the first genes unequivocally associated to non-syndromic obesity, which is the FTO gene, or the fat mass and obesity associated gene, this was identified and subsequently found to account only for about 1% of BMI heritability, leaving the rest still unknown. So subsequent studies have been able to show us that these sex-specific effects for men and women have now been able to demonstrate to us that these different loci for genes are actually more active and more present in women, particularly influencing waist circumferences compared to men. And this evident heterogeneity between men and women across many of these waist-hip ratio loci is a reflection of sex-specific genetic effects driving individual patterns of body fat. As a result, obesity results from interactions not only from genetic factors, but also how the environment modifies these genetic factors. We likewise recognize that it is not only genes that would be very important in dictating if an individual would be obese later in life. Epigenetic marks, or imprinting, actually affect gene expression without changing the DNA sequence. Furthermore, environmental exposures during a critical development periods can also affect the profile of epigenetic marks and subsequently result in obesity. It has also become increasingly clear that pre- and postnatal environments play critical roles in pushing predisposed individuals. So sometimes we might have obese mothers having also subsequently obese children because of this kind of epigenetic imprinting. Many genetic and environmental variables interact to cause predisposed individuals to become subsequently obese and diabetic. What is also quite interesting is the fact that obesity in the past was perceived as a disease of affluence. But what we recognize now is that it is also a disease of those who are marginalized economically. So that studies in the past, particularly in Britain, were able to appreciate that birth cohort studies across different generations in the 1940s, the 1950s, and the 1970s that contained comparable data on social class, childhood and adulthood, and BMI were subsequently analyzed. And they were able to conclude that these large inequalities in BMI exist both because of childhood and likewise adult socioeconomic inequalities. And because of this, we know that inequalities coming into a child's life generally become progressively larger at older ages in all cohorts and both genders. So that these BMI inequalities continue to persist throughout generations, so that despite policies designed to reduce them, and likewise new innovations from society, particularly technological advances, making more people sedentary, changes in food patterns, particularly food production, in making more calorie-rich food available to more masses, would then translate subsequently to a socioeconomic position that would cause subsequent inequalities in BMI. So again, social problems also again beget body mass index and obesity problems. We might also say that socially, there's also a problem when individuals with overweight or obesity are also discriminated, particularly because there are certain individuals whom we think would actually be motivated to lose weight if they are told that they are obese. But apparently, some scientific studies, particularly behavioral studies, have indicated to us that these individuals are more likely to gain weight if they were harassed or labeled as obese individuals. Data from different individuals in England, particularly looking at ages 50 years and above, were able to report self-reported weight discrimination. And the questions were, in your day-to-day life, how often have any of these following things happened to you? You are treated with less respect or courtesy, or you receive poorer service than other people in restaurants and stores, and people act as if they think you are not clever, or you are threatened or harassed, or some of us might be guilty, you receive poorer service or treatment than other people from physicians or even hospitals. Never to almost day-to-day were the range of answers for these individuals. And it was quite surprising that perceived weight discrimination, which was self-reported, was associated with the relative increase in weight over time, which meant that rather than encouraging people to lose weight, weight discrimination promoted weight gain and the onset of obesity in these individuals. As such, implementing effective interventions to also combat weight stigma and discrimination at the population level could also be able to help reduce the burden of obesity. And admittedly, this is something that us health professionals are not truly aware of. This is contrary to the common perception that weight discrimination might actually encourage individuals to lose weight. We might also be aware that there are certain reproductive conditions as an individual goes through life and puberty that would also develop in association with obesity. And one such condition would be polycystic ovary syndrome. It is a common heterogeneous endocrine disorder. It is actually the most common endocrine disorder among women, which is characterized by irregular menses, hyperandrogenism, and also the pathology or histology of polycystic ovaries. And the prevalence of PCOS also varies depending on which criteria are actually used to make the diagnosis. Nevertheless, the clinical manifestations would usually include an individual with oligomenorrhea or amenorrhea, hirsutism, and frequently infertility or inability to conceive. The risk factors for PCOS in adults would include type 2 diabetes and gestational diabetes. And it has also been seen that insulin resistance affects 50 up to 70% of women with PCOS, leading to a number of comorbidities, including metabolic syndrome, hypertension, dyslipidemia, glucose intolerance, and even overt diabetes. In our local institution study, during the time that I was also in training in the Philippine General Hospital, despite the patient population, we were able to appreciate that patients presenting with polycystic ovary syndrome, about 55% of them were actually overweight or obese. If you would now look at the different phenotypes, some patients might actually present with very severe polycystic ovary syndrome, in which case insulin resistance would also more likely be severe. Some of them might not appear to be very viscerally obese, but just appear to have anovulation and likewise hyperandrogenemia. And some of them might actually still be ovulatory, but nevertheless have the pathology of demonstration of polycystic ovaries on ultrasonography. And likewise, some individuals might just have mild polycystic ovary syndrome. And as we can see throughout this spectrum of patients of the different phenotypes of PCOS, insulin resistance appears to be consistent as a finding. Once an individual is now able to bear children, another factor that would lead to obesity would likewise be weight gain, not only during pregnancy, but after they had also delivered their pregnancy. And what we are able to see from longitudinal studies is that postpartum weight retention is a significant contributor to the risk for obesity, particularly at 1 year postpartum, including women who even had normal weight before they got pregnant. In this particular study in the US, they were able to appreciate that individuals, about 75% of the women who were included in this cohort, were heavier 1 year postpartum, leaving only 25% of these individuals who were new mothers who were able to return to their prepartum weight. And what they were also able to see was that women retaining at least 20 pounds were more often African American, younger, poor, less educated, or on public insurance. And these racial and socioeconomic disparities were associated with high pre-pregnancy BMI, quite consistent with the finding that it is truly not a disease only of the affluent, and likewise excessive weight gain during pregnancy. Nevertheless, this weight gain was attenuated by breastfeeding up to 6 months and likewise moderate exercise. So the lesson, maybe for individuals who have become new mothers, we have to tell them to be at least very conscious of their weight and would try to lose their weight within the first year that they had delivered. It might also come to mind that once an individual becomes a mother, motherhood entails certain lifestyle changes that may also lead to weight gain over time. And over here is the curve, not particularly of mothers, but of individuals who would be sleep deprived, maybe due to work, maybe due to home tasks, or maybe other responsibilities. And it has been consistently shown that if a person sleeps less than 7 hours a night, there is actually a dose-response relationship between sleep loss and obesity. The shorter the sleep, the greater the obesity, as typically measured by our body mass index and likewise our waist circumference. So that for this particular population-based study, they were able to appreciate a U-shaped relationship between sleep duration and likewise BMI. Those individuals who slept at least 7.7 hours had the lowest BMIs, and those with shorter and also longer sleep duration had progressively higher BMI. Over time, a woman would also age and would subsequently undergo menopause. And we do appreciate that menopause also causes changes, as seen earlier, in fat deposition and also in appetite. And for a particular person who is presented with a lot of calories per every meal, a study was able to show that individuals who would be randomly assigned to various kilocalories for lunch, for example, and likewise observed over time, the results that were appreciated was that exposure to higher kilocalorie weights, kilocalorie diets, particularly in individuals who were of menopause age, were more likely to result in higher total energy intake and likewise subsequent weight gain. And what would possibly be the driver for this mechanism? It has been recognized that estrogen receptors are also present in our brown adipose tissue. And we remember that brown adipose tissue in the adult would also be able to improve metabolism and likewise subsequently cause favorable metabolic changes. And these would not necessarily be stimulated with declining levels of estrogen with menopause. At the end of this presentation, we also want to be able to come back to something very important as an issue that would also be able to affect not only weight in women, but also for men. And this is actually exposure to endocrine disrupting chemicals throughout our lifetime. And these EDCs are broadly defined as chemicals that can interfere with hormone action. And these are usually chemicals that are designed, produced, and marketed largely for industrial purposes, or even in some natural foods, or even for us women, even in cosmetics. Public health interest has also been able to generate new data, particularly because they are thought of as agents that might actually cause earlier age at menopause and subsequent changes in metabolism. However, studies have yet to be able to conclude their associations with marked weight gain over time for women who would also be chronically exposed to these chemicals. So throughout our lifetime for women, we are able to appreciate that when there is an increasing visceral adiposity, we are very much convinced that there is actually a higher risk for cardiovascular disease and also metabolic disease. And it truly is a disease that begets more disease. So that what we are able to appreciate now is that throughout our lifespan as women, we may be able to see how we may be able to intervene in various points of our lives, depending on the factors that would be highly prevalent that would likely cause weight gain for that particular population. And I hope that at the end of this presentation, we are now able to appreciate obesity not as a stigma, but as a disease that needs multidisciplinary collaboration in its treatment and its management. Thank you very much.
Thank you very much, Dr. Añonuevo-Cruz. We're going to have a case presentation to actually put together or collate all these ideas and to actually link and collaborate with other specialties who help us manage the obese woman. And I'd like to call our distinguished panelists to join us on stage before we present the case. Our first panelist is actually the Vice President of FIBA, or the International Basketball Association. Of course, a member of its medical commission. He is also the chairman of the Institute of Orthopedics and Sports Medicine of the St. Luke's Medical Center Global City. May I call to stage Dr. Jose Raul Canlas. Our second panelist is an assistant professor of surgery and clinic surgery and chief of the section of minimally invasive surgery of the University of the East, Ramon Magsaysay Memorial Medical Center. He is the chief section of metabolic and bariatric surgery of the Asian Hospital and Medical Center, as well as the program director of minimally invasive surgery training program at the Siemens Hospital. Please welcome Dr. Miguel C. Mendoza. The only non-medical, but amongst all of us, I think is the most, how should you say, most qualified to speak on nutrition in the group. She's an immediate past president or past chairman of the Nutrition and Diabetes Board of the Professional Regulation Commission, founder of the first private nutrition therapy and diet clinic in the Philippines, as well as the first Filipina consulting nutritionist of the American Dietetic Association Specialty Group for consultation and private practice. Please welcome Mrs. Sanirose Orbeta. May I request Drs. Carisma and Dr. Añonuevo-Cruz to please join us on stage. It is not uncommon that we as cardiologists or as internists or even family physicians get requests from our patients for clearances, or we call now medical risk assessment for certain procedures, even certain diets, and even clearances for gym or enrollment in gym activities. And so our case this afternoon is actually something very familiar to all of us, and it's something that I'm sure you've seen in your clinics at one point in time. And our experts will help us manage or give us inputs on the management of this particular case. I'd like to start. So we're presented with AJ. She's a 48-year-old female, generally asymptomatic. She's perimenopausal, with a known history of hypertension allegedly controlled with metoprolol by an outside physician at 50 milligrams twice a day. And she comes to our clinic to ask for a clearance for an initiation of the Cohen diet. So this is something very common that we see in our clinics. On physical examination, AJ has a blood pressure about 145 over 80 millimeters mercury. Her BMI is at 31.5 kilograms per meter squared. She stands 5'3" and is weighing 178 pounds. No? So by the lecture of Dr. Carisma, she's classified as obese 1. No? The rest of the physical examination is unremarkable, including neurologic examination. Just roughly, these are her laboratories. Her FBS is 124 milligrams per deciliter, so she falls under the impaired fasting glucose category. 75-gram 2-hour OGTT is about 186. Again, falls into the IGT bracket. Her HbA1c, or her glycohemoglobin, is about 6.4. which is labeled as IGT2 or pre-diabetic. Her lipid profile are as follows. Total cholesterol is 260, which is obviously elevated. Triglycerides at 167, the targets are there. Her HDL cholesterol for a woman is on the low end. She has a value of 44 milligrams per deciliter. Her bad cholesterol, LDL cholesterol, is 153 with normal liver and thyroid function screening tests. So our question, which is the question that the patient asks you, that's why she comes to our clinic, is, will you clear her, Dr. Carisma, for a Cohen diet? Right, so come on. Before we let Dr. Carisma answer, or you cardiologists seated watching us will probably say, will I? There are, of course, some things we want to learn about or know the opinions of in terms of what we can do. Particularly, we begin with lifestyle and hopefully or maybe medical intervention. So we'd like to ask our panelists what she can say about the Cohen diet and other fad diets, as well as is there a particular dietary advice that you can give for this patient. We'll call Ms. Sanirose Orbeta maybe on the podium to help us dissect this case. Would you like to stay here, Mrs. Orbeta? Are you fine there?
Yeah?
Okay.
Okay. Can we show some of those slides that I had brought with me?
Maybe we can start the discussion before we show the slides, just maybe a few things.
Well, definitely she needs to lose weight. That BMI of 31 is way too high. And if you notice, most probably some of the things that she's eating is not really conducive to weight loss. That's why she has a BMI that's very, very high. So usually for us clinical nutritionists, we really give them a total calorie requirement. Because when they come to the clinic, they're overeating. Like for instance, I showed it here. I hope they can put it on screen. Oh. Yes, yes, but it's in my bag.
Okay. All right. It's here. Okay, we have it.
Oh, good. There. Okay. So we need a caloric count to really try to maintain our weight. And most of the people that are really obese and overweight, they're definitely overeating. So I brought to you some of... Okay. So we all need to know how much calories we should be eating. It's terrible because those very obese and overweight people who are sent to my clinic, they're overeating. And so sometimes I tell them, can we just cut your portions in half? And then you will really lose weight. But they said, ako, doktora, favorite ko yan, hindi ko may bibigay, I cannot give it up, no? So I brought here just a little slide that hopefully you will remember how little calories we really should be getting for our ages. Okay, so I brought here from the Food and Nutrition Research, and this was just taken recently. For females, From 19 to 29, 1930 calories. 30 to 49, 1870 calories. 50 to 59 years old, 1870 calories. 60 to 69 years old, 16 to 1610 calories. And 70 years and older, only 1,540 calories. So you can see how really little calories they have recommended from the Food and Nutrition Research, and this is their latest data. All right, so for the males, again, 19 to 29 years old, 2,530 calories. 30 to 49 years old, 2,420 calories. 50 to 59 years old, 2,420 calories. 60 to 69, 2,140 calories. And 70 years old and over, 1,960 calories. And this is the distribution ratio that we usually recommend. So for instance, a carbohydrate of 45 to 65%, this is the division that I usually use. And this is also recommended by the Food and Nutrition Research. Protein is only 15 to 20%. Fat is 20 to 25%. Fiber is 14 grams per 1,000 kilocalorie. And sodium is 2,300 milligrams for people who have no hypertension and who are also not diabetic. We give them 1,500 milligrams only of sodium. So look at this. If this is your favorite, so remember the calories that I have mentioned to you. One regular size of cinnamon is already 880 calories. So can you imagine only one? And if you remember your count, 1,930 calories. So you have there already your cinnamon. One, and somebody tells me, Mom, that is for my lunch. Merienda ko pa, isang ganyan. My golly, I said, you eat 2 cinnamon a day? So that's already your requirement of calories. How about your breakfast, lunch, and dinner? And you still have a bedtime snack. My God, so you can imagine that cinnamon of theirs, no? 880 calories. One regular slice of cheese pan pizza. Okay, so let's see the calories. 650 calories. You see? And you don't only eat one slice, don't you? You eat 2 slices at least. Okay, so there goes 1,300 calories already. All right? So, and then you have here, a serving of halo-halo. Let's see what's the calorie count of this. 520 calories. So, and then of course some people said, Ma'am, hindi namin kinakain yung ice cream. Regular lang. Okay, mas kinaalisin natin yung 120 calories, no? It's still 450 calories. So, you see, we are definitely overeating our allocation. Okay. So, we see, again, a cup of palabok, pansit palabok. Okay. Balewala yan, sabi nila, no? Okay, 300 calories. So, that's really very little. All right, I'm just flashing to you some of the breakfast, lunch, and dinner calories that we have served, no? All right, so this one is for breakfast, for instance. You have just half a mango. 1 cup of rice is 200 calories. And then, of course, you have there like paksiw na bangus, no? So all of that is only 297 calories with 1 cup of rice. That's why it's irritating when a lot of people come to my clinic and said, Ma'am, kaya namin alisin yung kanin. Bakit yung kanin ang inaalis ninyo? So, you see, they're very misled or misinformed. It's terrible because a lot of these fad diets now, I know it because they come to my clinic, Ma'am, kaya namin alisin yung kanin. Huwag nga yung kanin ang alisin ninyo, yung taba. Huwag kayong magkain ng lapid chicharon. Huwag kayong kain ng mga potato chips, kung ano-ano yung kinakain ninyo. And then, you will give up a very important nutrient needed for the body, which is rice. Okay? We'll see. What's the next one? All right, so we have here also another meal. Again, 200 calories for 1 cup of rice. So maybe if you can don't remove the rice, make sure to have some carbohydrate. So it's 1/2 cup of rice. So maybe 100 calories is minus. So that becomes already 346 calories, no? So you have there paksiw na isda, and then you have fresh pineapple, and then you have there, again, all the different kinds, no? Okay, so then we have, oh my gosh, I'm sorry. Mayroon pa atang isa dyan. Wala na? Okay. So anyway, what is important now is that to make sure, please, doctors, that you know exactly what you're putting in the mouth. You can see our drivers and our kasambahay and all of that. They don't see doctors. They're healthier than their amos because they're definitely eating correctly. They eat plenty of carbohydrates, which is rice. Kunti lang yung ulam, yung mga tira-tira lang natin. And then plenty of gulay. And they're drinking lots of water while their masters are drinking all kinds of juices and soft drinks and all that. No? So you can see that calories really are the ones that's most important. No? So the total amount of food is very important. Thank you.
Thank you. That really brightened the eyes of the crowd. If you can see your faces from where I'm sitting, it's amusing, just like probably my face. All right, we'll go back to the case. So you will have time to ask your own questions after all the panelists have given their insights or inputs about this. So we've heard from the nutritionist rather. We will now ask our sports and orthopedic expert here about an exercise program. Is there anything that he can advise, particularly for the age of our patient? She's perimenopausal and obviously obese. Let's hear from Dr. George Canlas.
Thank you, Len. My disclaimer, I'm an orthopedic surgeon. I basically do ACLs, I do reconstructions. But in my field of sports medicine, I come across, unfortunately, exercise-induced injuries. All right? So I might be a little opinionated with what I say, but I think in general, one, sports medicine, and I realize it's not just in sports medicine, it's a very sexist field. There are really differences between men and women. I'm sorry. Biology is destiny. Your structure is to bear children, so you have wider hips, you have knock-kneed, you don't have the testosterone, you don't have the growth hormone as much as men. So exercise has to be a little more supervised for you. Man is the hunter, women is prey. I'm sorry, but that's how it is. And another disclaimer, ma'am, kilala ko may-ari ng ano? ng Cinnabon. All right, basically, let me, the Cohen diet, for those who are not familiar with it, you go to a center, and they call it a Cohen Center. I had a colleague who got into trouble giving this lecture, so I have disclaimers. And then they take laboratories, and then they design a program for you, okay? And there are others. There's the Atkins, there's the, what are the diets? The South Beach, there's the Atkins, there's another. Atkins is the high protein, right? Okay, Atkins died of a heart attack, and an autopsy, he actually had myocardial, he died. So I don't have anything against these diets, even the Cohen diet. Basically, I think dieting and exercise go hand in hand in weight loss, whatever age you are, okay? I always tell my patients, you cannot use exercise to lose weight, all right? Your primary function in losing weight is still a diet. Case in point, those of you who do the treadmill, do any of the cardiologists do treadmill? Okay, sorry. I'm an orthopedic surgeon. Lenny doesn't consider me a doctor, so that's all right. If you do the treadmill, you're, let's say, 40 kilograms to 50 kilograms. You do the treadmill, 8 kilometers per hour. And those who do the treadmill, you know that's a brisk jog. In fact, 8 kilometers per hour for some of us is more than a moderate activity. You do 8 kilometers per hour at 40 kilograms, you do it for 1 hour, you lose at most 400 calories. Okay? That's even 1/2 of one Cinnabon. All right? So if you can imagine, if you want to lose that many calories, you have to do aerobic more than an hour, 2 hours. That's why the endurance athletes, the triathletes, the ultramarathoners, they're thin. But there is always a tipping point. In fact, I recommend exercise per day anywhere from 40 to 60 minutes. After 60 minutes, you're just inviting injury. My point is, if you use exercise to lose weight, chances are, especially if you're female, you will get injured. And a lot of them is knee pain, back pain, ankle sprains because of the weakness. Because 1, you don't have the testosterone. 2, you don't have the growth hormone. Unfortunately, that's how it is. That's why with women, you have to be a little more supervised. This is the recommendation of the American College of Sports Medicine. 30 to 60 minutes of moderate exercise. Now, for those of you who don't have the step counter, which I think is, the fitness industry is billions and billions and billions of dollars. So there's a lot of marketing involved, all right? As clinicians, you have to be very discriminating on what's marketing, what's not. That step counter thing, it just started with one company selling those counters. I prefer distances. Anyway, what is moderate exercise? If you don't have the heart rate monitor, if you don't have the step counter things, moderate exercise is doing an activity, whatever age group you are, where you can still talk to somebody comfortably. All right? You're pressing yourself, you're doing your aerobic comfortably. If you're just walking and you're talking side by side and you're not even exerting effort, that's not moderate, that's light. Okay, so if you want to measure it, it's talking, and it's only 30 to 60 minutes. In fact, what ACSM says is 150 minutes a week is to maintain. If you want to lose weight, you do anywhere from 300 to 400 minutes a week. But at that level, especially if you're obese, I think you're going to get injured. So the main factor you have to think is limiting your intake. And then you do exercise, 1. Second point is, fitness doesn't necessarily mean you're healthy. Okay, I see a lot of very fit people. They jump higher, they run longer, they swim faster. But a lot of them are not really healthy. If you take their blood, very recently, if you take blood markers for cardiac damage on extreme athletes, I think 60% of them will have elevated markers. Recently, a month ago, they did that for kidney. After an endurance run, swim or bike, you'll have increased kidney damage markers. Does that mean there's a long-term effect? We don't know yet, because we've just been doing that recently. All right? So take that in mind. Being fit is not necessarily being healthy. Now, why do these people like doing the endurance runs? 2 things. Cortisol in production. When you exert yourself, you increase your cortisol production. And a certain endorphin they call endocannabinoid. It's cannabis. It's marijuana. So there's a feeling of wellness. The thing is, there's an addicting property. So you develop a tolerance to maintain that same level of cortisol and endocannabinoid, you have to exert more effort. That's why you will have patients who want to start doing more and more and more. My point is, just smoke a joint, you'll probably feel the same way. President Duterte is a personal friend, so I don't know if I should be saying that. Another thing is, aerobic exercise is not the only exercise you should be doing. You should be also doing resistance exercise. Okay, especially for this patient, resistance exercise has been shown to improve insulin sensitivity. All right, since she's on the borderline, maybe resistance exercise has to do that. Again, you'll have to be very careful on what kind of resistance exercises you do. All right, if there is a take home from this, one, you have to know the limits, what you want to do with your exercise, and what you want to attain. All right, don't rely on exercise to lose weight because you will just get injured. You will have to remember you have to limit your intake. And I think that's what this Cohen diet does, this is what that Atkins diet does. Just limits intake. In retrospect, losing weight is actually a mental state. It's how much you want to take. Okay? Thank you.
Thank you, George. So the Cohen diet, which he says, no, it's actually a caloric intake. It's a starvation diet, that's what I call it. For those of you who really inquired about patients who seek your clearance, they usually go on a 700 to 800 kilocalorie diet. They weigh the food before they actually serve it. But the bad thing is for us cardiologists, they ask us clearance because usually the physicians who look at these special diets or these fad diets ask if our patients can stop their maintenance medications, including the statins. They're antihypertensives at times, and sometimes even their metformin or their medications for sugar. So it is important that we're aware of the fad diets, and it's important that we know, of course, the basic tenets, no? The lifestyle, so including nutrition and then exercise. But what if all these seem to be futile or they seem to be not enough, and your patients ask you, am I ready or am I a candidate for something more invasive like bariatric surgery? Who are the patients who are truly candidates for something more than just lifestyle or more than just pharmaceutical or pharmacologic rather treatment? Are there any cardiovascular benefits for this type? Of course, we know it's an acceptable modality. Are there any gender differences when we send our patients, right? At least particularly for women? Let's hear from Dr. Miguel Mendoza, Ike Mendoza, who's a bariatric specialist about this. Ike?
Thank you very much, Lenny, and good afternoon, everyone. It's an honor and a privilege to share this stage with distinguished panelists, and it's my first time actually to attend the Philippine Heart Association conference and meeting, and thank you very much, Lenny, for the invitation as well as to the officers of PHA. We've been doing bariatric surgery since 2004. I've been in practice since 1996 for 21 years, and bariatric surgery for the last 13 years. And may I just know from the audience, how many here have encountered in their practice patients who are obese, who you have advised to go into diet and exercise and failed repeatedly? May I see a show of hands? Okay. How many in the audience have recommended weight loss surgery, or known as bariatric surgery, to these patients to lose weight? Okay. We have to understand that bariatric surgery, and this I realized, is not an aesthetic procedure. The main reason why we perform bariatric surgery is to treat the medical problem. And that should be very clear to the patients. The beauty of bariatric surgery is that it is the only surgical procedure, when performed successfully by a multidisciplinary team, will it be able to treat maybe 3 or 4 or 5 medical problems at the same time. A lot of our patients that we see have concomitant illnesses. Type 2 diabetes, which is very common. Sleep apnea, which is very common. Hypertension, hyperlipidemia, joint pains, infertility, pulmonary problems. These patients have this. The indications for performing bariatric surgery are very clear, but the type of procedure that we do to our patients should be tailor-made. The indications are the following, based on the World Health Organization. Number one, we talk about BMI. Based on the World Health Organization, a BMI of 35 and above with comorbid illnesses like diabetes, hypertension, pulmonary problems, infertility, and so on and so forth, are candidates for bariatric surgery, provided these patients have had obesity for the last 5 years and have tried to lose weight in the last 1 year supervised and failed. Supervised weight loss for 1 year. And we see our patients, they come to us, they've been trying to lose weight for 5 years, most of the time unsupervised, and they lose some 20 pounds, but then gain 30 pounds, lose again another 20 pounds, gain 40 pounds, and we call this the yo-yo syndrome through diet and lifestyle changes. So it is not sustainable for a certain subset of patients. Another indication set by the World Health Organization as far as BMI is concerned is a BMI of 40 and above, even without comorbid illnesses. And the premise is that those patients with a BMI of 40 and above have a higher risk of premature death. And when we see these patients, they are in their very productive age years, mid-20s, early 30s, 40s. These are the patients that we encounter in our clinic. And of course, aside from these indications, they should not be involved in any substance or drug abuse or alcohol abuse. They must be compliant and understand what the procedure that they're going to undergo. We must manage their expectations as far as the result is concerned. Patients come to us expecting after the surgery they will lose weight. And it's a miracle procedure and they lose weight. It is not. 50% of the success of the operation for them to lose weight in order to treat the medical problem is dependent 50% on the team, the surgical team, as well as the other specialists involved, and 50% is dependent on the patient. Bariatric surgery is not just surgery alone. We have to have a cardiologist on board to ensure that the patient is fit to undergo surgery cardiac-wise. We have to have a pulmonologist involved to ensure that the pulmonary function of this patient is stable and strong. Patient may need a CPAP during or after the surgery. We need a gastroenterologist involved because the gastroenterologist, in some patients, they have acid reflux disease. And we have to identify Barrett's and some other problems, maybe esophageal carcinoma. We have to rule that out. We have to have an endocrinologist on board. Why is that? To ensure that the cause of the obesity of these patients is not a glandular problem, because bariatric surgery will not work. We have to have a physiatrist involved, or a sports doctor involved, or a physical therapist involved in order to prescribe the right exercise regimen for them after the surgery in order for them not to get injured. We also need a psychiatrist involved. Very important. No patients in our team will undergo bariatric surgery without first being seen by the psychiatrist. Patients come to us with a very high motivation level. They want the surgery done, they want to lose weight, they want to spend time more with their children who are still young, they want to get rid of their diabetes and hypertension. But the motivation level goes down after several months. So we need our colleagues in psychiatry or psychology to help us. So these are the specialists that we need. Of course, a nurse, an anesthesiologist, the nurse bariatric practitioner, and so on. To ensure the safe bariatric procedure, this multidisciplinary team should come into play. That's number one. Number two is we have to perform the procedure in a facility that is capable of handling obese patients. When we talk of obese patients, these are not patients who are 20 pounds overweight. These are patients who are at least 100 pounds overweight. So we deal with patients who are 350 pounds, 300 pounds, 400 pounds, even 500 pounds and above. We do their surgery for them to lose weight. And therefore, in a facility who plans to do bariatric surgery, and you don't know how much that chair, as far as weight it can handle, then we are in trouble. A patient who sits in a toilet commode, we don't know how heavy that toilet commode can handle, we will be in big problem. And therefore, in a facility who plans to go into bariatric surgery, all these furnitures in the room are marked with weight capacity. Bigger wheelchairs, bigger doors, bigger stretchers, bigger beds. So, what I want to tell the audience is that not only the indications in bariatric surgery, but the entire comprehensive preparation. It is not just surgery alone. Everything has to be well thought of. Patients come into the hospital for an elective procedure. And therefore, and these patients are special patients because of the multiple comorbid illnesses that they have. And it takes an entire team to handle and manage these patients. For this particular patient that we are having in this particular case, a BMI of 31.5 is not an indication to have surgery. We would recommend that these patients go back to their internist, undergo a plan for weight loss through diet and exercise. Only if diet, exercise, or medication, only if they have supervised plan and the patient gains more weight and the comorbid illness are there and they fall in the BMI of 32 and above or 35 and above, then we would recommend surgery. But there's one thing else that we should understand. These indications for bariatric surgery or weight loss surgery were given to us by our colleagues from Europe and North America, the World Health Organization. The BMI cutoff in the Asian population, and we have a group in the Asia-Pacific region, is different. The BMI cutoff is lower. For Asians, the BMI cutoff is 32.5 with comorbid illnesses. Indication for bariatric surgery, plus the other indications that I mentioned. And 37.5 instead of 40, even without comorbid illnesses, is indication. Why is that so? Studies have shown, and intra-op findings have demonstrated, that with the same BMI for an Asian and a Caucasian, there is more adipose tissue in the body of an Asian individual. Number two, with lower BMI in the Asian individual, there are more higher incidence of comorbid illnesses. And therefore, the group, which I belong to in the Asia-Pacific region, came out now with several recommendations, which has been approved as a consensus of the experts coming from the Asia-Pacific region. We now have our very own indication for bariatric surgery catered to the Asian population. And that is what I would like to share with everybody. Thank you.
Parang you're so quiet. No? So you can actually put out your calculators rather than just the cameras when you were taking pictures and calculate. But by eyeballing, I think the panelists will agree that there doesn't seem to be anyone in the 32.5 here. No? So, but these are all actually very new and very exciting and interesting data. Before I open the floor to the audience for any questions that you may throw to any of the panelists, maybe I can ask Dr. Chi Añonuevo-Cruz, how about pharmacologic management? Is she already a candidate? Do you agree with her medication? Well, we didn't indicate that she was on a statin yet, but she's on metoprolol as her antihypertensive. How about the implications on this for IGT? Maybe you can comment, Chi.
This patient has a diagnosis of prediabetes for both impaired fasting glucose and impaired glucose tolerance. And just looking at her HbA1c, we can tell that it has been around at least for the last 3 months. And knowing that she is at that age where we would really see a higher rise in the prevalence of diabetes, particularly for a Filipino patient, and likewise she is hypertensive and dyslipidemic and also obese, we want to be able to start not only lifestyle intervention in order to improve her weight and subsequent comorbidities, but likewise try pharmacologic therapy in order to prevent diabetes or even at least delay the progression to avert type 2 diabetes. And for these situations, a very simple regimen would be to start this patient, if she is able to tolerate it, metformin. And for this particular reason, we want to be able to stress to the patient that metformin, if started, will not totally guarantee not becoming overtly diabetic, but at least buy her time, so that during this time that lifestyle interventions would be in place, she would also be able to at least achieve better glycemic control in the long term. As regards her antihypertensive medication of metoprolol, for someone who has prediabetes, it has been theorized that a beta blocker might actually worsen this particular situation of insulin resistance, in which case, if there would be no contraindication, and should her cardiologist also agree, then an RAAS blocker would probably be more beneficial for this patient, knowing that blockade of angiotensin II would also alleviate some form of insulin resistance in this patient.
Thank you. I think that was very clearly explained. Will I throw the question out to the cardiologist after hearing all these? Dr. Carisma, will you clear this patient for a Cohen diet?
I am sure the rest of the audience will agree with me that tolerating discontinuation of statins, of antihypertensives, not to mention the starvation diet, which should not be in our vocabulary insofar as dietary recommendation to our overweight patients is concerned, is a definite no-no. It's, to me, almost suicidal. I am not that familiar with the Cohen diet, maybe because my area of practice is not in the affluent group. But Mrs. Orbeta has also made it clear that such diets, she has mentioned the fact that fad diets also have no place in the regimen for weight reduction among all our patients. As she showed, we still go by the food pyramid, yes, and the caloric count, distributing the calories equally, accordingly to the carbohydrates, proteins, and fats. Now, a word about the beta blocker metoprolol. Again, the cardiologists in the audience will also agree with me that following the most recent guidelines in hypertension, the JNC8, despite the fact that beta blockers have been with us as a guideline recommended treatment for hypertension much earlier, JNC8 has relegated it to a later line choice. No? We have the first line drugs that consist of thiazide diuretics, we have ARBs. Yes, I agree, Chi. The patient would be better off with an ARB or an ACE inhibitor to control the blood pressure, knowing that she has already impaired glucose tolerance. Metoprolol, I will also agree, will just promote her into frank diabetes. So that is not also to really bury the role of beta blockers in hypertension because they can still be used, especially with the third generation beta blockers, which have vasodilating properties, unlike the older traditional beta blockers, which have shown no benefits in terms of outcomes, as the meta-analysis have shown.
All right, I think it's been very clearly elucidated by our panelists. Now we have about 15-20 minutes for an open forum. If there are any questions regarding exercise, diet, medications from the audience, we are now opening the floor for questions. Any additional questions from management? Yes, Dr. Lopez.
Asians are rice eaters, and we have so many kinds of rice, the white, the red, the brown, even the black. Is there any difference as far as the caloric quantity is concerned?
None, only the fiber. Only the fiber. The fiber, for instance, for 1 cup of white rice is about 1.5 grams, you know. And if it is the red rice, it's about 3. And then if it's the brown rice or I don't know now, a lot of my clients come and say black rice. I said, so that's most probably same as the brown rice. So we give it about 3.5 to 4 grams of fiber per 100 grams of rice. So that's roughly about 1/2 cup. Yeah.
So it's safe to say that when they ask us if they want to lose weight, and then they'll say, but we're taking brown rice or red rice na. So in terms of calorie count, maliwanag yan. There is no difference in calories. Okay, that's a wonderful question.
Lenny, the only difference is the fiber.
Just the fiber.
The fiber.
So for those who are constipated, for those who are...
Yeah.
Okay.
In fact, Lenny, our academy don't like us to use the word diet because diet means restriction, it's abstention, it's not eating correctly. You know, they have a misconception when you use the word diet. You know, so they like us to use the word new eating pattern. Sanirose makes sure to give them the new eating pattern. So a lot of the doctors, ano ba yung new eating pattern? You know, they just change the word diet because diet means new abstention. It is foregoing your favorite foods. And as you have seen, that crazy cinnamon is already 800 calories, you know. So,
Matotrouble tayo nito kung may kamag-anak na cinnamon dito, Tita Sanirose. Yeah. I think we have another question from the audience. Please, Doctora.
Ma'am, how about what's the difference between corn versus taking rice for your... Because in our family, we always have both rice and corn because my mom prefers corn. Okay, and another question that I have is, I came across a diet which they call the ketogenic diet, and I cannot imagine how they can sustain eating only fatty foods and they do away with carbohydrates, and I can just imagine the cardiovascular effects despite losing so much weight from the ketogenic diet, which I can see in their pictures on Facebook.
Yeah. So the ketogenic diet, ma'am, is also called the caveman diet. No? So all they eat are meat, high fat. Actually, it's all fat. Yeah. Ma'am?
I usually tell them, you know, there are so many kinds of diets, you know, that they're talking about. And I tell them just to make sure that there is really no difference except the fiber. So if you want brown rice or white rice or dinorado and all of that, it's fine. No, I'm just so surprised because I don't know why it's in the mind of people, rice is fattening, rice is bad, rice is terrible. I said, look at the people in the provinces, they don't have doctors, they don't have anything, they never see. They're very healthy, they're eating 1 katerbang of rice and then gulay. And all the seafoods and clams, not like here in the cities where prime rib, all of these very high caloric fatty meats, you know. So I think it's really the choice of food. So if you eat the ratio that we usually propose, you know, the 55 to 60% carbohydrate, 15 to 20% protein, and 20 to 25% fat, that is the ratio that we usually give for healthy eating.
Ma'am, how about the difference between corn and rice? I think that was her first question.
Yeah, the only difference is a little fiber. But the carbohydrate, 1/2 cup of corn, is equivalent to 1/2 cup of rice. The difference is the fiber content of the corn is higher. Higher.
More questions? Yes, Tita Beth, Dr. Manlapit.
First of all, I'd like to thank everyone for the wealth of information gathered from the masterful presentation of our speakers, Dr. Carisma, Dr. Añonuevo, Cecille, and our illustrious panelists, expert panelists. My question to Dr. Añonuevo-Cruz is that, do you believe that malnutrition in the fetus and the newborn is contributory to the obesity of an individual? And if you do, what is the pathophysiology that is involved in that?
Thank you for your question, and I think that's also one of the reasons why in certain countries that are socioeconomically disadvantaged, we are also seeing a lot of individuals who also become obese very early in life. And the theory for this is that because of epigenetic imprinting, they think that the current or the intrauterine environment is something that did not fully make the pancreas develop, and sufficiently also there would not be enough beta cells that would be able to handle glucose load subsequently as the patient starts eating carbohydrates. And they are able to appreciate as well that these individuals who are born small for gestational age, this rapid catch-up within the first 1,000 days of life would also translate to subsequent disease in the future, knowing that they are accruing a lot more fat than they should be accruing at a faster rate. And for this particular reason, we are seeing more SGA babies becoming obese very early on in life. Probably also because of the fact that this catch-up growth, this particular catch-up growth with this barrage of calories, these patients are unable to handle these calories very well. And with a fairly immature or small mass pancreas, they are likewise unable to secrete sufficient insulin and make as well be able to drive glucose from the circulation into the cells. So I think one of the reasons why we are also seeing more obese children these days is that we also think that they have to be fed a little bit more very early on in life, which is not the kind of diet that they should, sorry ma'am, intake or nutritional plan that they should be having very early on in life.
That's wonderful. That answers your question, no, Dr. Babes? Any other questions from the audience? Yes, Doctora.
My question is for Dr. Mendoza regarding bariatric surgery. What is the risk of bariatric surgery? Is it really that safe? And would you accept a patient who is quite lazy to do diet and exercise and out of a whim will say, I'll just go for bariatric surgery?
Okay, thank you for that question, Doctora. That's a very good question. The risk. A lot of us are fearful that when we advise our patients to undergo bariatric surgery, being a major operation on an obese individual, the risk is very high. It is actually not. It really depends a lot on the training, the experience, the skill of the surgeon, and if he has an intact team with him. That lowers the risk. What is the data in literature as far as mortality is concerned for bariatric surgery? It is 0.28%. It is not high. It is even lower than other procedures, general surgical procedures that can be done. Because probably it is because we take that extra effort of ensuring that this patient is cleared in all aspects. The whole workup is given to this patient. And we choose the patients very well on who will undergo bariatric surgery. So that is the question, that is the answer to that first question. the risk is very low. But we have to choose the team who will perform the surgery, the institution where the surgery will be performed, and of course, the correct patient where bariatric surgery can be done. So these are the three important factors to decrease the risk.
So will you accept the patient who's lazy to exercise and just, she has a lot of money, she out of whim, she just wants to instantly, quote unquote, instantly, maybe over months, lose weight, and she will go through the procedure?
That is a very good question as well. We've encountered patients like that in reality. And the patient comes to us, says, I want the surgery done, I don't want to exercise, I don't want to see a nutritionist, I don't want to see a psychiatrist, cardiologist, okay, I will see a cardiologist, and I just want to lose weight. This patient will not have surgery with me. I will deny this patient that surgical intervention. At the very beginning, it's already a failure. The end objective is to ensure of a successful outcome for these patients. So even if the patient can afford, and practically those are the patients that will have bariatric surgery, they have to undergo this rigid screening process. Patient agrees to everything except a psychiatrist. That's a problem as well. And I've denied patients these things. Some of these patients try to manipulate other individuals, even their physicians, into following what they want. And probably that's the reason why they reached that weight of 400, 500 pounds. And we have to put a stop to that. And it starts in the clinic. So I will not let it.
Thank you. Yes, a follow-up question. We have room for one last question.
Just a follow-up question. Have you had patients undergoing bariatric surgery and then they gained weight again?
Yes. Yes, they did. And the reason behind this is we see this patient, in the early days when we were doing bariatric surgery, the most common procedure being done was a band procedure, a gastric band, which we place laparoscopically, small incision around the upper part of the stomach, creating a small pouch of 25 cc. The weight loss of this patient is dependent on the follow-up in the clinic. In order for us to be able to adjust the band so they lose 6 to 8 pounds a month, sustained consistently. If they lose follow-up, they don't follow up, they gain. So there's a subset of patients who belong to this group. No matter what we do, we try to call them, they don't follow up. Some of them traveled abroad, some lost to contact, and then you get emails from them and they gained weight. They have to come back. There are patients who lost weight significantly, 70 to 80% of their excess weight after a band procedure, after a sleeve gastrectomy procedure wherein we create a banana-shaped stomach from a ball-shaped stomach. 5 years down the road, they start gaining weight. Why? Their pouch increases. The restrictive component of the small pouch from the very beginning now increases over time. Then we have to do now a revisional surgery if indicated. But we have to examine the patient as a whole. A lot of these, I heard the word a while ago, is in the mental state of the patient. That has to be thoroughly investigated, why they regain. So yes, they do regain, if ever, 5 years down the road. But we've had successful patients even from 10 years back who still maintained a little above normal BMI, have lost from 500 pounds down to 240, 230 pounds. If they see a reconstructive surgeon, you take out all the excess skin, that's another 50 pounds. So they break 200. So these are the patients that we encounter.
Any last? Yeah, okay. We'll have a last question from the audience.
Hi, Doc. I'm Ria Fernandez from PTV. Doc, I would just like to ask again for soundbite kung ano po ba yung mga, or sino ba yung mga candidates for bariatric surgery, and what happens to the body when one undergoes bariatric surgery?
Okay, so yung mga candidates for bariatric surgery are those patients na, in layman's term, yung more than 100 pounds overweight. So more than 100 pounds above their ideal body weight. Okay, so sa BMI, that's 32.5 for Asians and above with comorbid illnesses, or 37.5 and above even without comorbid illnesses because of the risk of premature death. Yun ang main indication. And number two is compliance and understanding of the procedure to be performed. Importante yun. Walang substance abuse, importante na yun. So these are the candidates. And those patients with medical problems that cannot be treated anymore with usual medications, no, or lifestyle or diet and all these things, then bariatric surgery is an option. It is the last option after everything else has been tried. That's where we come in.
Sir, Doc, ano pong nangyayari po ba? Paano ginagawa yung surgery?
Okay.
May nababago ba sa loob nila?
Basically, sa bariatric surgery, meron tayong tinatawag na dalawang klaseng procedure. One is purely restrictive. Ibig sabihin nun, pinalit yung tiyan, we made the stomach small, no, to handle only around maybe 25 ml of volume, or probably sometimes 50 ml of volume. And that is basically restrictive. Pag kumain ng pasyente, busog siya. There is no sense of deprivation kasi what he eats is the same food that is set on the table during family dinner time. Except yung volume, kumonte. So may restriction, but walang deprivation. There's a procedure that we call the sleeve gastrectomy procedure wherein there is restriction and you take out half of the stomach vertically and the ghrelin hormone, which is located in the fundus, 90%, and 10% probably in the small intestinal tract, is also eliminated. And the ghrelin hormone is the one responsible for making them hungry. Konti na nga yung kinain, hindi pa nagka-crave. So that is one mechanism. And there's another set of procedures which we call restrictive na, malabsorptive pa, combined. Konti na nga yung kinain, very few volume of food taken in, and this volume of food taken in is not all absorbed by the body. So weight loss is fast. Very effective as well for patients with type 2 diabetes mellitus.
Very last question, how much does it cost?
So the cost, okay. I was expecting that question. Well, the cost varies depending on which hospital. But on the average, the patient will spend anywhere between 350,000 to 500,000 pesos. That is the cost. And depending on the type of procedure, the more complex the procedure that is tailored to the patient, the more expensive it becomes. But let us all remember, the more complex the procedure, the more side effects and complications for the patient. So it's very important to choose the right procedure for the right patient.
All right. In the interest of time, I know this has been really an exciting session, but we'd like to close the session and formally thank our speakers and our panelists again for a very enlightening afternoon. We'd like to call in the speakers and the panelists to receive their certificate of appreciation, which reads, the Philippine Heart Association and the Philippine College of Cardiology presents this certification of appreciation to Dr. Maria Belen O. Carisma, speaker during the PHA's 48th Annual Convention and Scientific Meeting, May 24th to the 26th, 2017, EDSA Shangri-La, Manila, Mandaluyong City. Signed, Dr. Leus, Dr. Nanetray, and Dr. Lapitan as President of the PHA. Congratulations and thank you. The same reads for Dr. Maria Cecille Añonuevo-Cruz. Chief. And the same reads for Dr. Jose Raul Canlas. George. And the same for Dr. Miguel Mendoza. And last but certainly not the least, this is Sanirose Orbeta. Stay on for the business meeting. Thank you very much for your attention.
And